Yo, what is going on, everybody? Welcome back. Today, I want to talk about um, esophageal disorders that are usually talked about. So we have achalasia, GERD, and scleroderma. Um, and this is the most important big picture slide. So kind of just ask yourself: is the lower esophageal sphincter, also known as LES, too tight or is it too loose? Um, If it's too tight, then you know it's achalasia. If it's too loose, then it gives you GERD or reflux. And destroyed smooth muscle gives you scleroderma. So, and this is an achalasia overview. So, achalasia is a failure of the lower esophageal sphincter to relax. So, it's due to the loss of nitric oxide secreting neurons in the Erbach or myenteric plexus. So, if NBME gives you uh, an answer choice that says like enteric ganglia for like the site of the problem, then that is the right answer. Okay. It can also be described as dilated esophagus with constriction of the GE junction. And an important thing to note is that um, you will have an increase in LES pressure. Um, and the the bird's beak is very important as well. Um, you also have to note that dysphagia occurs in both solids and liquids, and that's a very important distinction to make. Because like if you have like cancer or something like that, it like starts off with like solids, right? It starts off with solids, but then like it eventually becomes solids and liquids. But achalasia, it's like both at the same. It's like both, like when you get it. Um, yeah, and then remember the bird's beak. Very important. Let's go to GERD. So GERD is pretty much the opposite problem for achalasia. Instead of a tight sphincter, you have a very weak one. And instead of a high LES tone, you have a low LES tone. And so, because the LES pressure is very low, stomach acid will reflux back into the esophagus. And so, the issue in GERD isn't really obstruction problem, but it's more like you have injury from the acid that's from the stomach. So, um, you have to know that obesity is a risk factor for GERD, and hiatal hernia is also a risk factor. And the classic presentation is a patient who has burning in the throat or the chest after a meal, and um, it's worse when you're lying down. And treatment is PPI, um, and it's gonna decrease all the symptoms. So that's pretty much GERD. Yeah, it's so GERD is usually talked about because it leads to Barrett's esophagus and then eventually adenocarcinoma, and it's just like that's like why it's so talked about. But that's for probably another video. But yeah, I'm just trying to compare the three disorders. And now you have scleroderma. Scleroderma is very similar to GERD, but the mechanism is pretty different because scleroderma is an autoimmune disease, which causes fibrosis and smooth muscle atrophy. Um, and in scleroderma, the collagen, it replaces normal smooth muscle, so peristalsis is going to become weak, and the LES becomes extremely hypotensive, and this causes a severe reflux, which is often worse than GERD. Um, And in scleroderma, you have patients who have dysphagia from this, from the weak peristalsis, right? And they also have very high reflux symptoms. Um, so the way you can kind of differentiate between scleroderma and GERD is scleroderma is going to have like other random things like Raynaud's phenomenon or tight skin, Crest syndrome, and they also have like the anti-centromere antibodies. So it's very different from GERD in that sense. It's very multi-system, right? So if you have if you have decreased LES sphincter tone and a decreased esophageal peristalsis, then you have scleroderma, right? And just for your information, Crest syndrome. Crest stands for calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasias. So that's pretty important to know. And then this is the sample question. I'll give you some time to look over it, but I'm gonna review it in 5 seconds. 5, 4, 3, 2, 1. Okay, so the answer is F. Sorry that I didn't mark it down here. Now let's go over the question. Which of the following combinations of esophageal findings is most likely in this patient? 64-year-old woman presents with a progressive dysphagia to both solids and liquids for the past 6 months. Okay, I think just from this sentence, you're like thinking, oh, maybe it's achalasia. She also reports chronic heartburn and occasional regurgitation of undigested food. She denies weight loss. She has a long history of episodic finger dislocation when exposed to cold temperatures and nose tightening of the skin on her hands that makes it difficult to fully extend her fingers. Physical examination shows smooth, taut facial, skin, and digital contractures. Esophageal manometry is performed. Which of the following combinations of esophageal findings is most likely in this patient? So I guess like it began, you might have been like, oh, this is achalasia, but as we kept reading, the vignette, it points to scleroderma, right? It's like you have all these like random like skin issues. You have the esophageal issues, right? You have Raynaud's, you have sclerodactyly, the skin tightening, right? You have facial skin tightening as well, and you also have the progressive dysphagia with the reflux, right? So it's pointing to scleroderma, but then you're like, oh wait, that's not an answer choice, bro. Yeah, NBME loves to do this. Like you might figure out that it's scleroderma. And sorry, like I forgot to mention, there's even this picture, which is like the first thing that you should look at, and you should be like, wait a minute, like why would they give me a picture of this finger or this hand if it's achalasia or GERD, right? So it's like the answer is definitely this picture is definitely answering is pointing to scleroderma. So now that we got there, they like hit you with this, right? They hit you with, oh, like how is the peristalsis and LES tone? Well, we know that in scleroderma there's gonna be weak peristalsis because the collagen has like pretty much taken over, right? We've discussed that we discussed that in scleroderma that the collagen is going to replace the normal smooth muscle, and therefore peristalsis is going to be weak, right? And so we know that peristalsis is going to be decreased. So boom, off the bat, you eliminated 4 questions. Now you're stuck with LES tone, and we know that the only thing that has increased LES tone is achalasia, right? And the reason why the LES tone in scleroderma is decreased is because you have an incompetent LES, and that's why you get the acid reflux, which leads to the heartburn, right? Which she says there's chronic heartburn, right? So that's why it's low peristalsis and low LES. Yeah, that's That's a good way. Yeah, sorry that was so messy. So, I think to tackle this type of question, you definitely, read the last, read the lead in question, read in sentence, right? And then obviously just read the whole question. But then the first thing you should be doing after you read the question is definitely looking at the picture and like asking yourself like, okay, how does this picture relate to what the question is about? Because this is the last objective finding. The picture is always the last objective finding, and it's always going to be like the answer. Like it's always going to be related to the answer somehow. They don't give this pictures for free, like for fun. So after you look at the picture, you look at, this esophageal is not that important, but you look at the physical examination and then, bottom up, right? And then, um, once you reach your diagnosis of scleroderma, then you're like, okay, then you gotta kind of think about like how that works. And we know that peristalsis is going to be decreased because collagen replaces the smooth muscle, and we know that, and therefore the LES is going to be incompetent as well. So that is kind of how you tackle that question. And you're gonna get definitely more difficult questions where like the diagnosis, but you might not know certain details about the diagnosis, and that's kind of why I think STEP is a difficult exam. Yeah, but this is just a quick summary. Um, if you just need like a refresher on everything, just gonna leave it there. Um, yeah, and then life tip. Um, Today's life tip is gonna be about kindness. So you might think that you're a really nice person because you say like, oh, you always say thank you to the waiter, or like to strangers you're really nice, and people just like always like people that you barely know, you treat them really well. But and that's great, and I really encourage you to keep doing that. But I think being nice, being kind is really shown and tested when you're dealing with people inside your house. So that could be your family members, that could be your spouse, your girlfriend, boyfriend, whatever. But if you are truly nice to them, then that's part of your character. Because and the reason I say that is because the people in your house, they know your history, right? So they know who you are. They don't know just this person that they've met. And so even with all that they know and all that the fact that you continue to treat them well and be nice to them, I think that is what makes you a truly kind person. So that's the encouragement for today. Um, it's great to be nice to strangers, but be even nicer and be even kinder to those who live under the same roof as you. Okay? Appreciate you guys for watching. Peace.